We would like to inform you that the Union is a secretariat of the Leadership Summit on Tobacco Control, a virtual event to take place 6 and 7 of May 2021. The registration to the summit opens in January 2021. The scientific program will feature Michael Bloomberg, Stephen Donnelly, Minister of Health of Ireland, and other
Hi, everyone. Welcome to the session today. My name is Omara Dogar. I'm one of the chairs of the session. Welcome to the session today. My name is Omara Dogar. I'm one of the chairs of the session. And I'm an assistant professor at the University of York in the UK. From background, I'm a medical doctor trained as an epidemiologist. And I work both in the UK and internationally on areas of global public health relevance, particularly tobacco use and lung health. My main interests in research includes implementation of behavioral interventions and designing methods for measuring intervention delivery to understand the real world utilization of these interventions. Now over to my co-chair.
Yeah, thanks, Omara. I am Dr. Sonu Goyal, working as a professor of health management in Department of Community Medicine and School of Public Health in India, one of the autonomous National Institute of India. So I'm a medical doctor by profession, as Omara is. And besides this, I have been associated with Union for last 10 years. And I'm a visiting faculty of sorted program of operational research, currently vice chair of tobacco control section, chaired by Omara. And I'm also handling Empower Research Group. And I'm also director of E-Resource Center for Tobacco Control, which is there in our country. And I teach public health to Masters of Public Health students, MD and PhD, and had some publications primarily on tobacco control. So over to Omara.
Thank you, Sonu. Thank you so much. Now we will kindly request the speakers to introduce themselves one by one before we move on to the presentations. Over to the speakers.
Okay. Hi, everyone. My name is Shahara Kure and I'm from Sri Lanka, but currently I live in Germany pursuing my master's degree in agricultural economics. I work for Movendi International and my main interests are on tobacco and alcohol control. And basically that is my background. Thank you.
I think we are missing one speaker, I Wahayam, but he will hopefully join us for the Q&A session. So I will request the next speaker to introduce themselves. Alexander, over to you.
Good morning, everyone. My name is Alexander Chu. I'm a first-year medical student at Dell Medical School at the University of Texas in Austin. I've been primarily working in epidemiology of TB, primarily in Peru. And my presentation today will be about the effect of recent smoking cessation on the transmissibility of TB in children. And I'm coming from the United States, currently signing in from Austin, Texas.
Thank you, Alexander. Can I please request Sneha now?
Good morning, everyone. I am Dr. Sneha Malhotra. I'm pursuing post-graduation from Maulana Azad Institute of Dental Sciences. Thank you all and welcome as well.
Thank you. And over to you, Garrison.
Hello, everyone. My name is Garrison Spencer, and I'm a public health analyst with RTI International's Center for Global Non-Communicable Diseases. I do a lot of work in health economics, quantifying the burden of tobacco, also looking at obesity, hypertension, and looking at the return on investment of different interventions to address those. And I am coming to you from Seattle, Washington today.
Thank you, Garrison. I see that our last speaker, Ivan, has also joined. So please, can I request you to introduce yourself?
Yes, sure. Good morning, everyone. My name is Iwayan Gede Artawane Kaputra. I'm from Bali, Indonesia. I work for Udayana University in School of Public Health, Faculty of Medicine. I'm a lecturer and a researcher. I focus on tuberculosis control program and also on increasing the compliance for smoke-free legislation in Bali, Indonesia. Yeah, that's all.
That's great. Thank you so much. Now on to the presentations, and then we'll come back for Q&A after that.
Hello everyone, welcome to my presentation. And my presentation is about monitoring and comparison of the global tobacco and alcohol industry's response to COVID-19 pandemic. My name is Shahara Kure and I'm representing Movendi International. So why should we consider about tobacco and alcohol use when it comes to COVID-19? It is a fact that tobacco and alcohol kills millions of people around the world in a year. And tobacco smoking is one of the risk factors for many respiratory diseases. And smokers are more likely to develop severe complications with COVID-19 compared to non-smokers, according to WHO. And also that when it comes to alcohol use, it is a risk factor for more than 200 diseases, and including non-communicable diseases, and it weakens the immune system of the humans, and it has negative impact on personal hygiene and physical distancing rules, and it increases the risk of acute respiratory distress syndrome, which is one of the severe complications of COVID-19. So overall, the total effect of tobacco and alcohol use during this pandemic is still unknown, but emerging evidences suggest it can be severe. So what happened with the COVID-19? There's a growing resistance for sales and marketing of tobacco and alcohol around the world. And there's pandemic containment measures like lockdowns of countries and physical distancing rules. And there's global and national governments and health agencies advise against tobacco and alcohol use, and not only limiting to the policy measures, but there's a growing need and attention of community for boosting immunity, and therefore refrain from health deteriorating products. So all these factors making together a perfect storm for tobacco and alcohol industries to regain the market and corporate reputation while surviving the industry. I'm moving to the methodology of my presentation, and I'm using an explorative and qualitative study using secondary data sources. And I've developed a conceptual model to compare the tobacco and alcohol industry response to COVID-19 and to expose their commercial motives behind all these responsive activities, and to make recommendations to overcome the industry interferences. So when I move to the results of my presentation, tobacco and alcohol industry both have increased the focus on corporate social responsibility activities through targeted donations, monetary-wise and material-wise. We have been seeing them donating ventilators, hand sanitizers, and other medical equipments to targeted countries, and especially the alcohol industry was engaged in producing hand sanitizers. So behind this hand sanitizer production, we should not forget that they have excess production of alcohol, which doesn't have anywhere to go because of the decline of demand in alcohol throughout the world. So they make it an economic opportunity to use this wasted alcohol for hand sanitizer production. So it is not only for corporate social responsibility aspect, but it also gives them a commercial benefit. And both of these industries being investing in COVID-19 research and vaccine development. There's a one solid example that where British American Tobacco and Philip Morris International were involved in coronavirus vaccine development using tobacco plant leaf as a major component of the vaccine. And there's from alcohol industry too, there have been funding for virologic researchers and behavioral researchers around the world. And not limiting to doing marketing through CSR activities and also funding in research in vaccine development, they also interfered in policy implementations of tobacco and alcohol ban throughout the world. So one solid example is from South Africa when they imposed a ban on tobacco and alcohol for 21-day lockdown period. Both industries were aggressively lobbying the government to gain the market opportunity again. So to remove the ban and reopen their sales outlets. So their arguments were always like the same, that they wanted to emphasize that it increases the illicit alcohol and tobacco, and also it loses the government revenue, and the illegal cigarette and illegal tobacco alcohol markets will grow with these measures. And not limiting to all the policy interferences and marketing, but they also make it a chance to collaborate with global NGOs. So we can see from tobacco industry and both alcohol industry, a solid example is Abin Bev was making money donations to UN Women and American Red Cross, the humanitarian organization, and also global UN institutions. And tobacco industry and alcohol industry, after doing all these unethical marketing practices, they further continue their marketing through social media, exploiting COVID-19 via using misconceptions and misleading concepts through misleading hashtags and misleading campaigns in social medias and both in print media. I'm moving to the conceptual model of my study. As aforementioned tactics being used, there are hidden benefits and motives of tobacco and alcohol industries, like ensure sustainability of markets and therefore increase profits, and to overshadow the harm and regain the corporate reputation, and using this charitable image to delay or prevent the government regulations on sales and marketing bans, and confuse science and promote their platform products and second generation products, and also build new relationships with NGOs. So I recommend there's a need for consistent monitoring of both industries to gain insights to anticipate industry counter strategies, and to strengthen the implementation of WHO CTC Article 5.3 and Article 13 in the to control industry interferences. And there's a need for rapid development and substantive implementation of global binding treaty on alcohol control. And there's a need for raised level of understanding and among decision makers about industry strategies during this time, and exposing industry CSR projects and their hidden commercial objectives to public. So I would like to make conclusions that global tobacco and alcohol industries use same strategies in response to COVID-19 pandemic for their commercial interests. Therefore, there's a need for consistent monitoring and comparison of both industries to gain insights about industry behavior on coping with this pressure from global health agencies, and to anticipate the industry counteractions via their CSR projects and excessive lobbying. So I suggest exposing more of tobacco and alcohol industry CSR projects and their hidden commercial objectives to general public, raise level of understanding among policymakers about these strategies, and also the strengthening of implementation of Article 5.3 and Article 13 in the WHO CTC, and rapid in development and substantive implementation of global binding treaty on alcohol control. I would like to conclude my presentation, and thank you for listening. Have a nice day.
Okay. Thank you very much, ladies and gentlemen, for this great opportunity. I would like to present my research in Bali, Indonesia. So I declare there is no conflict of interest. This is our title of our study in Indonesia is the violation of smoke-free workplace policy in Bali, Indonesia, and the next strategies to improve compliance. The background of our study is smoke-free workplace is a part of the implementation of smoke-free legislation in Bali province since 2011. It is important to assure clean and healthy air to workplace, to raise awareness of smoking harm and encourage smoking cessation and increase productivity, particularly to the workers and the visitors. The implementation should be strengthened through a strategy innovation that develop based on evidence. So the objective of our study is first to assess the violation of workplace smoke-free, to assess the violation of workplace smoke-free policy by criteria, to assess the violation of workplace smoke-free policy by type of workplace, and to determine the workplace smoke-free, to assess the determinant of workplace smoke-free violation. The methods of our study, this is a survey at workplace in Bali province from January until February 2020. The workplace were divided into government workplace that run for public services and private workplace that owned by company for business. Sample were selected using stratified random sampling. Data collection following time and area observation guideline start indoor area, then at the outdoor area. Observation was conducted for at least 20 minutes for each workplace using Open Data Kit mobile application. Okay, this is the continuation of the methods. The key indicator of violation were presence of people smoking indoor, presence of e-cigarette using indoor, presence of cigarette butt indoor, smell of tobacco smoke indoor. And the determinants of violations including no smoking sign, ashtray provided, designated smoking area indoor and outdoor. This is the result of observation by type of workplace. In the table 1, we saw that the violation, the fourth violation, is higher in government office compared to private office. We also assess the number of violation observed, that violation in government office is 3 times higher compared to private office or private workplace. And we also assess the determinant, for example, no smoking signage, and ashtray provision, designated smoking area. We also found that the determinants of the violation also better in private workplace compared to government workplace. And this is the factor of workplace smoke-free policy violation, or we call this the determinant of the workplace smoke-free policy violation. We found that no smoking signage is the factor of violation prevention. The smoking signage, no smoking signage, particularly indoor and outdoor, prevent the violation of smoke-free policy. Ashtray provision, particularly indoor, is the factor of the violation. Also, the designated smoking area is the factor of the violation. And we found after control the type of workplace, these 3 factors is strong associated to the violation. No smoking signage is prevent violation, and ashtray provision, designated smoking area is a factor to encourage violation. The fact that violations were higher in government workplace was a paradox because they should be a role model on the implementation. Random inspection should involving all tobacco control advocacy team and journalists because the news regarding the violation and punishment are giving strong deterrent effect for the employee and official of government office. Since the capacity of random inspection team are limited, an internal monitoring team at each workplace are important to announce the policy to visitor and remind and prevent the violation. The signage is one of key success to smoke-free policy implementation and mandatory in all workplace. The manager of workplace have important role. They should responsible on the signage and clearly understood the concept of smoke-free policy. Enforcement should include complete removal of ashtray and also eliminate the designated smoking area indoor. Workshop involving workplace managers should be conducted to harmonize the perception and arrange plan for action to improve the smoke-free policy implementation in the future. Our study have a limitation, particularly the capacity to capture real situation because the surveyor were not observed the workplace along their working time, but only 20 minutes. So we try to minimize the limitation by observing in the peak time. So we hope we can prevent false negative. False negative means a result that found no violation, but the fact was a violation. We prevent the false negative. The conclusion is high violation on presence, but cigarette smoke, smell, and ashtray provision show the ignorance of and low awareness of manager and employee in the area. The implementation of smoke-free workplace policy in the government office was inconsistent. They put the signage, but they did not comply. No smoking signage and ashtray elimination should mandatory in government and private workplace. Stronger strategies should implement in government workplace, such as workshop and supervision for office manager. Internal monitoring also important. Internal monitoring team building at each area to prevent violation and random inspection for enforcement. That is a critical also to improve the compliance for two smoke-free policy in the future. That's all our presentation. Thank you for your attention.
So before I start today, I just wanted to openly declare that I do not have any conflicts of interest to disclose as the speaker for today. So good morning, everyone. My name is Alexander Chu. Today, I'll be talking a little bit about the effect of recent smoking cessation in TB patients and the risk of TB infection in child household contexts in a prospective cohort study in Peru. So we know that based off of data from observational studies in humans that smoking cessation reduces the risk of TB disease, mortality associated with TB, and other poor treatment outcomes for TB patients. We also know that from animal models of tuberculosis that smoking cessation can also reduce bacillary load and tissue histopathological lung damage. And there's also some evidence to suggest that smoking cessation can improve immunological function and control of TB. But despite these understandings, we still had identified a couple key unanswered areas where there's some outstanding questions. So the first one is, how does quitting smoking after onset of illness help? In other words, do you need to have quit smoking for a very long period of time before you start to see the benefits of smoking cessation? Or can you start to see those benefits in a much shorter time frame? The other question that we had was, how does quitting smoking also affect the transmissibility of TB? So this led us to ask the following research question, which is, what is the risk of infection in child household contexts of index TB patients who recently quit smoking? In other words, is there an impact of recent quitting on transmissibility of TB? So we conducted a prospective cohort study in Lima, Peru. So the figure here on the right just shows the study catchment area in which we worked with the red dots denoting the 106 participating health centers from which we were recruited and worked with the study participants and patients with. So this image is Villa Maria de Triunfo district, which is one of the districts that you can find, and it shows to kind of give a perspective of the characteristic shanty towns that you would find in the study setting in which we worked with. As I previously mentioned, we conducted a prospective cohort study between 2009 and 2012. We recruited specifically 4,500 pulmonary TB index patients and 14,044 household contacts. So this was our two main study participant groups. I'm going to mainly focus on the household context denoted by the red timeline at the bottom, as that is the study group from which we had our main analysis outcome for. So at baseline, we assessed the TST status in the household context that did not have a prior positive TST result or a TB history. And we repeated the TST at 6 and 12 months, given that they were negative at the prior time point. We also assessed for TB disease at 2, 6, and 12 months into follow-up as well. So there were quite a few outcomes for the overall cohort study, but for the purpose of this analysis, in which I'm presenting the results for, we mainly focused just on baseline TB infection. Again, so this is a prevalence measurement of TST positivity for the household context at time 0 at the bottom left of the screen for the household contact timeline. So this slide just shows the flow chart or the algorithm by which we defined or classified index patient smoking status in our analysis. So we had 905 drug susceptible index TB patients that had child household contacts. And at the time of the survey, we inquired whether or not they ever smoked in one's lifetime. If no, they were classified as never smoked. And if they did report that they ever smoked, we further inquired whether they currently smoked at the time of the survey. And if yes, they were then classified as current smokers. And we further ascertained and subdivided their smoking status based off of the intensity of their current smoking behavior at the time of the survey, and defined light smoker, which was defined as 1 cigarette smoked a day, or moderate/heavy smoker, which is greater than 1 cigarette smoked a day. If they did not report that they currently smoke at the time of the survey, we further asked whether or not they had quit smoking within 2 months prior to time of TB diagnosis. And if yes, they were then classified as having recently quit smoking. And then we further subdivided to X light smoker and X moderate/heavy smoker using the same classifications for the current smokers as above. And all the remaining index patients were then classified as having quit smoking in the distant past, specifically greater than 2 months prior to time of diagnosis. So for the analysis, we focused specifically on children, mainly for methodological reasons. So this is a graph showing the relationship between baseline TST positivity and household contact age. And as you can immediately see, the TST positivity increased significantly with household contact age in the cohort. And if you focus on the age range for the adult household contacts, which we define as 15 years old or greater, so everything to the right of the red dotted line that you see on the screen, you can notice that the TST positivity becomes really high in some age ranges, over 50% in some areas. And so we made a determination that it was going to be very difficult to discriminate or differentiate between transmission that occurs within the community versus transmission that occurs within the household due to the index patient. And that's why we resorted to working with child household contacts, which had a lower TST positivity. So this slide just shows the baseline characteristics of the 2 study participant groups. Here in blue on the left is the drug susceptible index TB patient. So the main thing I want to direct your attention to is the smoking status. You'll notice that the vast majority, 90% of the index patients were classified as having never smoked, with a 1 to 1.5% for the active smokers and about 4% evenly split for the recently quit index patients. And here on the right for the child household contacts based on their exposure status to the index patient smoking status, you see a very similar distribution as well. So this is our main results slide. So this shows the adjusted prevalence ratio and 95% confidence interval for the baseline TB infection after we adjusted for the covariates listed at the bottom of the slide. So as I previously mentioned, child household contacts of index patients who were classified as never smoked served as our reference category. So the first thing I would direct your attention to is if you look at the child household contacts of active smokers, i.e. light smokers or moderate/heavy smokers, you'll notice that there's a gradation or dose response increase in the point estimates for baseline TB infection with increasing index patient smoking intensity. And that was a finding, and specifically child household contacts of moderate/heavy smokers were 2.20 times as likely to be TST positive at baseline compared to child household contacts of index patients classified as never smoked. And this was a finding we were able to replicate based on our findings previously published in 2014. The novel thing here is if you look at the child household contacts of index patient who recently quit, i.e. X-light smokers and X-moderate/heavy smokers, you notice that the trend goes the opposite direction. And specifically, we did not find a statistically significant association between exposure to X-moderate/heavy smokers and baseline TB infection, suggesting that recent smoking cessation reduced the increased transmissibility of that is normally associated with active cigarette smoking. So in summary, X-moderate/heavy smokers who quit within 2 months of diagnosis had a similar risk for transmitting TB as non-smokers. And the key implication here is that promoting smoking cessation among people diagnosed with TB may help reduce transmission of TB, particularly in settings with high cigarette smoking and TB rates. So I just wanted to thank briefly the study participants, as well as the investigators and collaborators based primarily in Boston, United States, as well as in Lima, Peru for making this study happen, as well as the NIH and NIAID for funding the study, also making it possible. Thank you very much for your attention, and I look forward to your questions if you have any.
Good morning to those sitting in the West and good afternoon to those sitting in the East. Before I begin my presentation, I'd like to declare that there is no conflict of interest to my report. I, Dr. Sneha Malhotra from Department of Public Health Dentistry, Maulana Azad Institute of Dental Sciences, would like to present my research titled Effectiveness of Two Methods of Tobacco Cessation Among Tuberculosis Patients Visiting DOT Center, Delhi, that is in India. As we all know, tuberculosis is a primitive disease and is a leading cause of death worldwide, killing 2 million people per year. India being the world capital of TB. And to overcome this burden, India initiated a national TB program in the year 1962. Later, in 1997, RNTCP was formulated, which is the most systematic and cost-effective approach. Tobacco being another epidemic, killing more than 7 million people per year. Evidence suggests that exposure to tobacco is associated with higher risk of TB infection and adverse outcomes like relapse of TB and TB mortality. TB and tobacco are hence world's greatest public health problems. As there is substantial evidence to support this association, there is a strong need to integrate tobacco cessation intervention into TB program and clinical services. Literature shows paucity of data regarding the effectiveness of different approaches in tobacco cessation. Few studies are done in other parts of the world using brief advice and use of other methods only on smokers. Hence, the present study was conducted to assess the effectiveness of two methods of tobacco cessation among tuberculosis patients visiting DOT centers, Delhi, that is in India. The objective being to assess self-reported tobacco quit status among TB patients at different time intervals being first week, first month, third month, and sixth month. Also, to measure nicotine dependence pre and post intervention and to know the predictors of tobacco cessation among these patients. Hence, this figure is illustrating the flowchart of the study design. All patients, pulmonary and extrapulmonary TB patients, consuming tobacco in any form and aged 18 years and above reporting to the study center were recruited and randomly allocated into the two study groups. These groups were Group A and Group B. Group A were patients who received behavioral counseling as a conventional method of tobacco cessation, and Group B were those, in addition to behavioral counseling, received nicotine replacement therapy in the form of nicotine gum. These patients were later followed up at different time intervals as told, first week, first month, third month, and sixth month. To elaborate more in details, I'd like to explain this illustration. This illustration depicts that after recruitment at baseline, patients were motivated to set a quit date. Subjects, as told in Group A, received behavioral counseling, and those in Group B received, in addition to behavioral counseling, nicotine replacement therapy in the form of gum, which is advised to be used using chew and puff methods. These patients were then followed up at first week, first month, third month, and sixth month. Subjects for both the groups received a counseling session of 30 to 40 minutes. At follow-up visits, patients were reviewed for their progress and problems. Behavior change was assessed using trans-theoretical model, withdrawal symptoms, and quit status was assessed. In addition to these questions, those in Group B were inquired about adverse effects of nicotine gum. At 6-month follow-up, contact session could not be carried out due to sudden outbreak of COVID-19 pandemic. Hence, as per government guidelines, the follow-up was carried out using a basic protocol of telephonic follow-up developed and used for research study, keeping in mind several variables all at once. To conclude the results, these are as following. Our study subjects showed that they were greater in proportion using smokeless tobacco form when compared to smoke and dual form. Also, more than 50% in both the groups revealed peer pressure as the reason for initiation. These study subjects, 46.7% in Group A and 42.2% in Group B, revealed that their age of initiating tobacco was 15 to 20 years. This below graph is showing the distribution and comparison of self-reported quit rate in between the two groups. As you can see in Group B, there was a gradual increase in self-reported quit status being 80% at 6 months. Whereas if you see Group A, there was a drop in the self-reported quit status in third month, which gradually increased to 57.8% by sixth month. These next two graphs, as you can see, are very much self-explanatory, showing the mean FTND score, that is the nicotine dependence score, where there was a gradual drop in the nicotine dependence from baseline to 6 months in both the groups. And this difference was statistically significant both within the groups and between the groups. Hence, before the beginning of our study, subjects had 4.4% had switched from smoking form of tobacco to smokeless form of tobacco, maybe because of a harm reduction strategy. Also, as told, there was a statistically significant in mean Fagerstrom tobacco nicotine dependence score in both the groups. The reason behind this could be the role of behavioral counseling in reducing the inclination towards tobacco use, making the patient more motivated to quit. Also, patients are more receptive to investigators' advice to quit tobacco use due to increased concerns about their health. There were several predictors identified in both the groups. These were, as we can see in the slide, literacy, social class, tobacco initiation, role of family environment, and nicotine dependence. As we all know, the habit of additional habit history will interfere with the success of tobacco cessation and can be detrimental. To conclude, we can say the present study has demonstrated the effectiveness of behavioral counseling and nicotine replacement therapy as a tobacco cessation intervention. Though the quit rate achieved with behavioral counseling and nicotine replacement therapy was greater, we cannot ignore that behavioral counseling alone can be a form of essential first step in the chain of support and is effective and feasible in assisting tobacco cessation. Behavioral counseling alone can be routinely performed as any other standard procedure in patient management. Besides this, pharmacotherapy along with behavioral counseling can be different but complementary role in tobacco cessation. Combination of this can result in better quit rate. A few recommendations I'd like to highlight here is there is a need to strengthen referral system to experts for difficult patients and patients with tobacco and other substance addictions and comorbid conditions. Besides this, there is a need for training and capacity building of stakeholders involved in national programs at all levels. Incentivizing the programs in form of money, reimbursement, or vouchers will motivate health workers and can be a concrete award. Tailored individual health promoter material in local language can also be an effective solution. Hence, the nexus of TB and tobacco needs to be broken or separated. Aggressive tobacco control measures integrated in TB control could avert millions of deaths. Implementation of such strategies will not be accompanied by any deterioration in the quality of services provided to TB patients. Hence, a comprehensive care approach to address this problem will yield better results. These are my references. Thank you so much. Thank you.
Hello, my name is Garrison Spencer, and I'm a public health analyst at RTI International's Center for Global Non-Communicable Diseases. First, I state that I have no conflict of interest. Today, I will be talking about a series of investment cases for tobacco control that we have conducted in sub-Saharan Africa. First, I would like to provide just a brief definition of what an investment case is. At the most basic level, investment cases provide evidence to support why a country should invest in a given policy, in this case, tobacco control. In doing so, we answer three questions. What is the health and economic cost of tobacco use? What gains can be achieved through tobacco control policies? And do the gains outweigh the cost of implementing the policies? Or put another way, is it a good investment? The 5 countries in which we conducted investment cases, that is Chad, Cabo Verde, Zambia, Madagascar, and Sierra Leone, have smoking prevalence ranging from 5.4 to 16.2%. And while these are lower rates than other regions, the increasing population and consumer purchasing power in Africa have led to a more accessible market that big tobacco is intensively targeting. And so it's really important to implement policies to keep these rates from growing. And that leads us to the Framework Convention on Tobacco Control, or FCTC, which these 5 countries all have ratified between 2005 and 2013. And the FCTC contains a list of demand reduction measures, including the 6 that are listed here. And these are all included in our model. You may also hear these referred to as the Empower policy package. And unfortunately, while these 5 countries are obligated to implement these policies as signatories to the FCTC treaty, there has generally been very weak implementation. And so the goal of the investment case is to demonstrate the health and economic benefits of these measures and accelerate their implementation. So here is a visual representation of the model we use to conduct the investment case. We begin by quantifying the current level of death and disability caused by tobacco use in a country. We next estimate the resulting costs from tobacco use. We then estimate how that set of tobacco control policies would affect smoking prevalence. We then estimate how that reduction in smoking prevalence would change health and economic outcomes over a 15-year period. We estimate how much it would cost to implement those policies. And finally, we can compare the costs and benefits to estimate the return on investment. So now let's go ahead and take a look at some of our results. So here we have again the smoking prevalence in each country, resulting in over 21,000 deaths between those 5 countries in just 1 year. And there are several types of costs that we include in the model. There's the direct costs of healthcare expenditures from treating tobacco attributable diseases. And then there are indirect costs from premature mortality as people die earlier than they would have had they not used tobacco and are no longer able to contribute to the economy. Smokers miss more days of work than non-smokers, so there's the cost of absenteeism. Even when they are at work, smokers are less productive than non-smokers, an effect known as presenteeism. And then there's the cost of unsanctioned smoking breaks. So that's the time that smokers are taking above and beyond non-smokers to smoke cigarettes. And altogether, these costs add up to a significant burden ranging from 0.5 to 1.5% of GDP. And as you'd expect, the burden as a percent of GDP does correlate with the smoking prevalence in a country. Here I wanted to show the cause of death for all of those tobacco attributable deaths and how a country's place in the epidemiological burden or transition impacts what tobacco attributable deaths are most common. So we often associate tobacco use with non-communicable diseases, but I wanted to highlight that lower respiratory infections, mainly pneumonia, is the leading cause of death here. And tuberculosis is the 3rd leading cause of death from tobacco use. And this is the 21,000 deaths between all 5 countries here. Just for comparison, in the US, lung cancer is the leading cause of death from tobacco use, while here it's down at number 7. When I highlight this here because it shows how tobacco use makes you vulnerable to infectious disease. And we see that now with COVID-19. 4 recent meta-analyses have shown that smoking roughly doubles an individual's odds of experiencing severe COVID outcomes. And finally, here we have the case for investment. So implementing these 6 policies could save over 100,000 lives over 15 years. And if we look at the return on investment, or ROI, we see that all of the policies have a return on investment greater than 1. So that means the economic benefits outweigh the implementation costs. The green boxes here just indicate that a country has already implemented that policy to the fullest effect, and so it was not included in the model. You can see a pretty large range of ROIs here, with taxes and bans on advertising tending to have the highest ROIs. There are several reasons behind the different levels of returns. For example, Cabo Verde has a very small population, so there are a lot fewer people among which to spread out the costs between. Another reason is the starting point in terms of the beginning level of policy implementation, the starting tax rate, the starting smoking prevalence, as well as the costs, local costs in a country all affect the return on investment. Another thing is that a policy like taxes can always continuously be increased, whereas a policy like plain packaging, it's either implemented or it's not implemented. You cannot continuously increase the level of implementation of plain packaging. So you'll see that taxes across the board have a higher ROI than plain packaging does. But the key message here is that implementing tobacco control measures is well worth the investment many times over. And that message has been really well received in these 5 countries. There is evidence that the investment cases have served to help push forward tobacco control legislation in several countries. I've included here some news articles from these 5 countries that has helped spread the message from the investment case that by investing in tobacco control policies now, countries can not only improve health, but also reduce health expenditures and grow the economy. And with that, I'd like to thank you for your time, and I look forward to answering any questions you may have either during the Q&A session or by reaching out to the contact info I've listed here on this slide. Thank you.
Hi. First of all, thank you all the speakers for a very lucid and nice presentations. And I think we have covered a variety of topics in this sessions. So I'd like to start with the question which has been posed by Prabhakara for regarding what it is basically on smoke-free presentation. I think it is the presentation 2. And he has asked that what are the reasons for non-compliance of workplace smoke-free in government settings compared to a private workplace. So what are the reasons for non-compliance of workplace smoke-free in government setting compared to workplace, private workplace? So our presentation, the second presenter from, I think, Indonesia.
Yes, Mr. Sonu. Thank you. Yeah. Okay. For this question, there is actually there is no difference for compliance criteria between government workplace and private workplace. The criteria of the first is the evidence of smoker, including active smoking indoor, and then providing ashtray, because that's mean the manager of area facilitate people smoking if providing ashtray. Also providing designated smoking area, also that is the violation. And our policy, smoke-free policy in Indonesia, particularly in Bali, also already include the e-cigarette smoking. So the definition or criteria of violation between government office and workplace, there's no difference. The difference is for health facilitation. Health facilitation must be 100%, including the outdoor area. But in private and government workplace, same. Yes, that's all my answer.
Thank you. Omara, can you pose the next question here?
Yes, thank you, Sonu. And yes, thank you, speakers, for taking the questions. The next one I'm going to take is for Sneha. And the question is, smoking cessation intervention in India, do TB patients need to pay the NRT cost or not? If it's free of charge, is it included in a TB care package in India? So over to you, Sneha, if you can please take that question.
Yes, ma'am. Thank you, ma'am. I'd like to answer that question. Currently, there is no integration of the strategy of integrating the use of nicotine replacement therapy to the currently running RNTCP program. So this was just a research topic, and so there is this was not beared, but the cost was not beared by the patients. This is provided by our institute as a part of research. So the answer to it is that there is no integration yet, but we hope it will occur soon in the future.
Thank you, Sneha. And I can, there are some follow-up questions, so we'll go on to those. But just before that, I can open it to other colleagues here. Do they have any idea if an NRT is freely available in India, or it's not part of the smoking cessation efforts as yet? Anybody can take this. Yes, Anu?
I'll just try to take that.
Yeah.
NRT, yeah, it's the state level in India. The drugs and the health is a state subject, so it depends on the state to state whether they want to have NRT in their essential medicine list. So there are few states which have now have NRT in their essential medicine list, but few states are yet to have that in their project implementation plan or the essential medicine list. So still there are few states which lack NRT in their routine essential medicine list in India.
Thanks, Sonu. Thanks. That's really helpful. And generally, because I also work in the area of tobacco cessation quite a lot, we have been, and Sonu has been doing a lot of work in South Asia. And really, even in terms of evidence, we don't have so much evidence of effectiveness and cost effectiveness of pharmacotherapies in these countries. We're trying to build more research in that area, and hopefully, I think we will get there where NRT and other effective drugs might be added to the essential list. But there's a lot of work that needs to be done. Sonu, can I just follow up the questions that are for Sneha, because they're all connected to this?
Yeah.
Okay, so the next question is, what was the compliance to NRT among the group B patients? Sneha, this is for you.
Thank you, ma'am. As my group B patients were 45 in number, all were very much receptive to my advice, and they were very much compliant to the dose of NRT that was advised to them. So they were very much compliant.
Okay, thank you. And were there any side effects that were reported for NRT use?
No, ma'am. No, ma'am.
Sure. Thank you. Over to you, Sonu.
Yeah, thank you, Mara. I think there was an interesting talk where the two policies, tobacco and alcohol industry policies, were compared. And so I think the question was, they complemented this very interesting presentation indicating how the similar tactics they are taking to normalize tobacco use and alcohol use. And the presenter has very nicely depicted those in their slides. So what the question by Akihiro, so that is question is about, would you elaborate a bit more about the countermeasures to industry interventions at country level? So what are the countermeasures to industries, these two industries, tobacco and alcohol, at the country level? So could you please elaborate on that?
Yeah. Thank you for the question, first of all. And yeah, I think in my presentation too, I mentioned that there are 5 main strategies I proposed. And I think mainly we should be very vigilant about what industry is up to first, so we can plan our countermeasures. And then I think the raising level of understanding of the decision makers about what these tobacco and alcohol industry is up to during this time is essential. So we should always complement with scientifically proved facts to the policymakers. So we should make sure that the science and the policy making is well connected, and thereby raise the level of understanding of the policymakers, and also to expose industry CSR projects and the hidden commercial objectives of those. I think those are very essential. And yeah.
Thank you, and thank you very much. Very nice explanation, I think, yeah. So I think we have a few more questions. I think one question which has been put by Prabhakar from India. Mm-hmm. So I think he has very nicely pointed out that integration of all health program with tobacco control program is very crucial. So I think that is the need of our, and it's not a question, it's actually a comment. And just want to reiterate, and I think Omara can follow it up, and based on our wide experience. In India, we are moving towards that integration where like a lot of other programs, whether it is non-communicable disease control program, the TB program, oral health program. So all our tobacco is moving in a integrated fashion with them. And I think we are piggybacking up with these programs so that some of the other objectives which has to be achieved by those programs, so tobacco control also achieves its objective. So like to hear from Omara more about that integration, and then followed by our speakers.
Yes, thank you, Sonu. I've been part of a lot of this work for the last 10 years, where we've been trying to implement and integrate tobacco control, tobacco cessation efforts within TB program, mainly in Pakistan, but also Bangladesh, Nepal. And with colleagues from India, I think they've been having the same kinds of efforts. And these are small steps, because some of the interventions that we implemented were based on behavior change techniques and behavior change theories from the West. And we soon realized that the systems work very differently, and it's a health systems integration more than just an individual behavior change approach. So with time, we have ended up kind of integrating them within TB messages. So messages for TB transmission, TB adherence to the TB medication, and so on. And that seemed to be the only way to take this forward for TB patients. But also along this journey, we realized that what a big effect tobacco smoking has on a TB patient, not just mortality, but in terms of morbidity. So, the number of patients who relapse just because they were smokers compared to the non-smokers, or the people who actually are successful in their TB treatment because they stopped or quit smoking. And I think those are the kinds of messages that are really important. And the tobacco cessation or the tobacco control advocates and researchers know the answers, but it's the risk communication to the TB world. So the TB practitioners, the TB program managers, that, this is where the piece is missing, where you have a lot of return on investment, just like one of our speakers said, Garrison. Those are the kinds of things that the policymakers want to see. They want to see what's the evidence there and how much they can save on investment. And similarly, I found really interesting when Alexander was talking about his research that ex-moderate heavy smokers who quit in the past 2 months had the same risk as non-smokers. This is something new which I haven't seen in research so far. And I think this can be really well translated for policymakers and into policy. So these are the kinds of things we need to pick up from the research and translate for our TB program, for our policymakers. And the effort needs to just keep going, because TB, tobacco, HIV, there are some of these diseases which when they interconnect or intercorrelate, they are synergistic and they do much more harm than they do on their own alone. So that's my take home message. But I would like to open this to our speakers as well, to Alexander and to Garrison, if they want to talk a bit more about this, and Sneha.
Yeah, I would just add that not in any of these investment cases, but these are a subset of 24 total investment cases that we're working on. And some of the other ones, we actually have looked at offering brief cessation advice from primary healthcare advisors. So integrating that tobacco control into the primary healthcare system in a couple countries. Also offering NRT and setting up a tobacco quit line. So there are some other things that we've looked at. What happens with those is that the return on investment is going to be a lot lower, because we go from these population level policies that we're looking at in these 5 countries to something like training primary healthcare providers to offer advice to smokers to quit. The cost of implementing a program like that is just by the nature of it, an individualized intervention going to be much higher, and the return on investment is just going to be lower. And what we really tried to do in the investment cases is try to not emphasize too much comparing the return on investments to each other, because we don't want to say, well, just do the one with the highest return on investment, because really these policies are going to work best and they're going to be the most effective when they're all implemented at once, because a policy that reaches one smoker might not reach another one. And brief advice to quit smoking might be really effective to one person, but not being able to smoke in a bar might get someone else to quit. So we really emphasize that, like, just because something has a lower return on investment does not mean that it should not be implemented. So thank you.
Thanks, Garrison. Thanks for adding that. Anything else from any other speaker before we move to the next question?
I think one of the presenters, one of the participants have Dr. Gopal Chauhan, who is working as a state program manager in state of Himachal Pradesh, has pointed out that they have incorporated tobacco control in almost all the programs, like whether it is NPCDCS, that is a non-communicable disease program, whether it is a blindness control program, tuberculosis control program, CKD, COPD, de-addiction. So N number of programs they have tried to incorporate tobacco control. And Himachal is one of the states where I think it has been a role model state in our country for many tobacco control interventions. Yeah, so just to take away.
That's very commendable, I guess. It's a real effort that shows that you have been working in this area and making the efforts probably ahead of other South Asian countries and in the region. That's a really good example. I would be very interested in looking at the effects and the evaluations of these programs and what you come up with. So maybe sometime,
Yes,
Gopal,
sure.
we will.
So, Umara, do you want to take this? If there is no further, do you want to take further questions?
There is one more.
Yeah.
So this question is for Garrison. And the question is by Garima Bhatt, and they're saying, in units of time, where is Southeast Asia region to implement the suggested slab of taxes on tobacco products by the WHO? Garrison, do you want to take that question?
Yeah, so we, in terms of taxes, we have conducted investment cases in Cambodia and in Myanmar, and we are currently right now working in Laos. And the initial taxes there, I'm not going to remember the exact rates, what they are or what they were, are pretty low. So what we do in the investment cases is we model the effect of increasing taxation so that taxes represent 75% of the price of a package of cigarettes. And in some cases, that is a pretty substantial increase from where countries are starting. Again, I apologize. I'm not going to remember exactly what the rates were for those countries, but I would be happy to share. Some of those reports are posted online, and if we could get in touch, I'd be happy to share the links to those investment cases for those countries.
Yeah, I think. Thank you, Garrison. There is one more question by Prabhakar, that what are the key factors for integration of health programs with tobacco control? So I think a very pertinent question, because everybody agrees to the fact that integration is really important if we want to succeed, because we always get a sort of a slide where I always remember that slide where the investment in tobacco control is quite less as compared to the burden, which is quite more in tobacco control, tobacco as a tobacco. So as far as my experience is concerned, when we built the integration of various health program in tobacco control, so I think the first thing, as Omara has very rightly said, is we need to create a win-win situation. We need to go with to the policymakers saying that this is what the tobacco control as a risk factor can do a havoc in your program. So if we just remove that piece of tobacco control, so I think your mortality, your morbidity, your disability adjusted life years, the cost implications, as rightly pointed out. So I think that can go significantly down. So this is what the evidence which we need, and we need to gather more evidence, like the research which has been presented in this forum and elsewhere, that we need to build those evidence and go to the policymaker with those evidence. So this is one. Second thing is we need to expand our community, tobacco control community. We have a relatively smaller community, which is of course expanding now. So we need to build that community. We need to take many people in our loop, and be it a psychiatrist, be it a community physician, be it a cardiovascular surgeon. So all people are dealing with tobacco control. So I think we need to take everybody into loop and put that agenda through their forums, which they are existing in their meetings. So I think this is another way which we can advance tobacco control. The third thing which I feel is really important to build integration is to have joint meetings, joint meeting with the secretary, right from the secretary level, the top level to the bottom level. So those joint meetings are really important, and the role allocation to different departments. I think that will make a huge difference. That will not only reduce the duplication of the work, but also synchronization of each of our work. So I think these are the three from my end. So Omara, if you want to add, and I think any other speaker want to add on, what are the factors?
Thank you, Sonu. I think you've covered the giant in integration that you need to consider. And at a very closer level of integrating with another program, I think what I've learned in my 10 years of integrating tobacco control within TB programs and TB clinics has been that you're coming from the tobacco perspective, but you also need to understand the demands that are on the TB system and the TB policymakers, the kinds of things they need to consider for your cessation program to be integrated within their program. So you have to be understanding, and you have to co-create something with them. So we started with, for example, the first trial that I did was a 40 minutes behavioral support to be integrated within TB program, to be delivered by the DOTS providers to the patients who were smokers. It worked very well. The smoking cessation rates were really good. It was a very effective intervention. But when it comes to implementing, the program and their providers did not have the time to implement it. So you come back in a cycle where you are trying to integrate and learn lessons from some such things. And eventually, over 10 years, we've reduced that kind of cessation to a very brief advice, which is integrated within advice for TB. And that's easier for the DOTS facilitators to implement. But it's also less burdensome for the patient, because these are sick people you're talking about. They don't have an hour to sit for behavioral support for smoking cessation, for example. So these are very small examples that I'm giving you from my practical experience. But over years, we've been able to co-create with the TB program, with the patients, with the providers themselves, something that is feasible, something that is effective, and that is also possibly cost effective. We are still doing that research part. So I think the key to integration is understanding what are the forces in place, what is the demand, what are the time constraints and the cost constraints. And then you're able to contextualize whatever you are doing in that particular context. And something that works in one place might not work in another. Something that works in a primary care setting does not work in a tertiary care setting. So you just have to be adaptable to all those when you're doing implementation and integration. So that's just my take on that. Anything else from other speakers?
Anything which worked in your setting anything like I think Omara has very nicely shared what worked in her settings in Southeast Asia that was key to integration. So any other key point other than the things which were discussed? Because integration is a very interesting area right now, and we need to integrate tobacco control with other. So anybody can come forward and share their experience. Yeah, from Indonesia.
May I add one point? In the experience, not only integrating tuberculosis and smoking cessation, but also to other program, not only non-communicable disease. For example, a mother and child, mother and child health. So we can ask to all mother when visit the primary health care about their husband smoking or not, to decrease the exposure of second-hand smoker in their house. That is important, not also only to the mother and child health, also in the nutrition program. For example, in the developing country and underdeveloping country, if there are a child with undernourished condition came to primary health care, this one of the indirect factor is smoking in their family. For example, the father is smoking, so the budget for nutrition is shared to the smoking behavior. That is also important to integrate the smoking cessation program to the all health program, including mother, child health, and nutrition also, not only TB and non-communicable disease. I think that is my point, sir.
Very rightly said. I think the community involvement is really important. The families also play a very important role, and they need to understand. They need to understand about the concept of how this non-communicable diseases are actually linked, and they need to change the behavior. So I think that's another very good point. So I just want to share an experience before we. I hope there is no other questions which are there. Umara, do we have any other questions in the speakers list?
No, I can't see any other. So I think, yeah, we can go on and wrap up.
Yeah, so just want to share an experience because there was a study on cessation. So we did a brief intervention, as Umara has been doing in Southeast Asia. So we did a brief intervention in one part of North India. And that was a brief smoking cessation intervention. We call it ABC package. Ask, brief, advise, and cessation. So it was a cluster randomized trial and on treatment outcomes as well as on the smoking cessation rates. So there was some interesting finding which was there, although we could not find the significant amount of treatment success rates, difference in treatment success rate between the intervention arm and the control arm. There was almost equal, but the smoking cessation was significantly reduced. Smoking cessation happened actually in intervention arm more as compared to control arm. Maybe because of we did maybe the study was there for 9 months time. Maybe we could have taken the longer outcomes, but that was interesting finding. It was a small pilot study which we did and published. So I think Umara, so I think you found in Southeast Asia, you found both treatment success rate as well as smoking cessation has been quite,
Yeah, so I mean, I can share quickly about a multi-country trial that I was part of that we published results recently. It was in Bangladesh, Nepal, and Pakistan, and we recruited 2,500 TB patients. And we did a smoking cessation, behavioral support intervention, and cytosine, which is a pharmacotherapy, and quite cheap for low and middle income countries. So we wanted to see its effect. However, we did not see that cytosine was more effective statistically than just behavioral support. What we did see as secondary analysis of the data was that those who had quit compared to those who did not quit were much more successful in their treatment outcomes. Their relapse was lower. So relapse of TB was lower in those who had quit. Their sputum conversion rates were quicker than those who were still smokers. And similarly, the treatment success rates and the outcomes that are considered by the program, the TB program. So from the national data set, we saw that their treatment success rates were better than those who continued to smoke. So I think these are really, really important outcomes in terms of TB, and one of the very few studies which had a big enough sample size to look at those differences. And I think that will be going forward in the national strategic plan and everywhere as evidence that smoking cessation does make a huge difference in TB patients. So yes, that's just what I wanted to share about our study. I think there is a question in the chat which we can quickly talk about, and then I think we need to wrap up.
Yeah.
So Sonu, I'll just go over this and then see if you want to answer it. How can we mandate in policies for incorporation of tobacco control themes in schools' course curriculum, especially in Southeast Asia, focusing on adolescents?
I think this already has been there for quite some time now, but I think this is a very relevant question, considering the fact that we have tobacco-free educational institute guidelines, which was there in 2009 and now revised in 2019 in India. So that calls for few things to be declared as a tobacco-free educational institute, like having something in tobacco control related topics, tobacco use related topics in the curricula, regular monitoring mechanisms, regular educatory talks, assemblies, the talk in assemblies. So all these things are already there. But the only thing is the various ministries, like there is a lack of coordination between health ministries and we are still in the development phase with the other ministries. So I think that coordination need to be developed, and we need to, and as we talked earlier, that that collaboration is needed at each level, right from the secretary level to the down level at the ASHA or the baseline worker. So that needs to be there. So I think this is my experience, that the things are already in place. The implementation is the issue.
Yeah.
So, yeah.
Thank you, Sonu. I think we can now wrap up. So I would really like to thank all the participants. This session could not have been so interactive if it wasn't for your questions and your engagement with us. And I would really like to thank our speakers for taking out the time and showing us such useful data in the area of tobacco control. And the whole host of range of topics we've discussed today, from tobacco industry's interference in COVID-19 to tobacco cessation within TB and the case for investment. These are really interesting topics, and I think these are the way forward, and all the things that we need to consider around tobacco control, the challenges that we are facing. But there's a lot of good work also going on. So with that note, I will also thank you, my co-chair, Sonu, and hand it over to Sonu to say, your ending remarks before we close.
So thank you, Mara. I really echo your thoughts that our participants were quite engaging. And I think we were almost on time. We had a number of questions on very various aspects with all speakers. And I also thank all the speakers for very nice, lucid presentations, which you all have made on different aspects. And really, I think it was some, even for me, some new thoughts were there. Garrison talked about few aspects of costing and newer things. And Vedant talks about like cessation and the tobacco smoke-free places. Sneha talked about cessation at a made. So I think it was a very wonderful session, and really, I think it was an insightful session for me too. So I thank you all for joining this. And if Umara, shall we close this session now?
Yes, we can close it. Thank you, everyone. Thank you very much.
Again.